In this unit, we will talk about swallowing and swallowing disorders. It's interesting to note that treatment and evaluation of swallowing disorders by speech-language pathologists is relatively new in our field. It's a relatively new job responsibility. It started in the late 70s and 80s that swallowing began to get attention from SLPs. And then in the 90s, Jerry Logeman is someone who was very prominent in getting swallowing to be a part of our scope of practice. The reason why feeding and swallowing is a part of our scope of practice is because the same muscles and structures that are involved in speech are the same ones that we use for swallowing. So, it makes sense for the speech-language pathologist to diagnose and treat swallowing disorders. Of course, they're working in collaboration with other professionals to help diagnose and treat appropriately. So normal swallowing is called deglutition, where a swallowing disorder or difficulty swallowing is called dysphagia or dysphagia. It can be pronounced either way. So dysphagia is defined as moving food or having difficulty moving food from the mouth to the stomach. And this can be a wide variety of symptoms. So it can be controlling the food or saliva within the mouth. It could be coughing before or during or after swallowing. It can be a sensation that the food is sticking in the throat or is unable to be swallowed. So there's a lot of different problems that can occur with swallowing. So you really need to make sure you understand the anatomy and physiology of swallowing. On page 190 and 191, your book does a really good job of explaining it. Just know that the brainstem, the brain cortex, peripheral nerves, and 25 pairs of muscles are involved in swallowing. It's very complex. The oral cavity, the pharyngeal and laryngeal cavity, the respiratory system, the esophagus is all part of the swallowing process. The lips, the teeth, the cheek, the tongue, hard and soft palate, they're all part of the preparation of foods for swallowing. The oral cavity, the salivary glands provide the moisture. The epiglottis, which we've talked about before, that's found in the pharyngeal cavity, it's very important because it flips down during the swallow and covers and protects the larynx. So if you remember that picture of the larynx that we have seen in your other slides and other PowerPoint presentations, that epiglottis flips down and covers the vocal folds so that food cannot go into your lungs. That the food goes over so that it can go into your esophagus. There's also a picture here that shows you some of the structures that are involved in swallowing. Here's a little bit better view of some of the anatomy. Within the pharyngeal cavity, there are these pockets called vallecula and piriform sinuses. They are recesses and provide safety to help food or liquids from entering the larynx. So they are kind of a holding area. Sometimes they can get trapped in those holding areas though, and so they'll spill over sometimes. So they've kind of pocketed there and then they spill over into the laryngeal cavity and then eventually into the lungs. So one thing that we're really trying to look at in dysphagia or dysphagia is the patient aspirating? Are portions of the food that are supposed to go into the esophagus and then into the stomach, are they going into the trachea and the lungs instead, which is what we don't want. The cricopharyngeus muscle is a very important part of the swallow. It remains closed during swallowing to prevent air or even reflux from the stomach from entering the pharynx. So that tightness and an opening of that muscle when you feel the need to burp, that's the cricopharyngeus. You feel that feeling of something tightening and wanting to open. That's what happens when you are burping. The laryngeal system is involved with breathing and the production of sound. That's those vocal fold vibration. We've talked about that extensively. But during swallowing, the larynx is closed so that you're protected. So your lungs and trachea are protected. So let's look at the phases of swallowing. There are 4 phases. The oral prep phase or preparatory phase. That's where solids and liquids are manipulated to form what's called a bolus. And that's kind of a ball, or how you move the food into a ball. So the saliva is mixed with the food and it's making kind of a ball in your mouth. During this prep phase, the soft palate and the tongue is used to gather up all the material in the oral cavity. Then there's what's called the oral phase. So this is after the bolus has been formed and the individual is moving that bolus to the back of the mouth and you're getting ready to swallow. So that's the oral phase. There's movement in this phase. The tongue elevates, pushes against the hard palate, and moves the bolus to the back of the mouth. This phase is typically really fast. Just like the oral prep phase is pretty fast, but this one's even faster. This is like 1 second almost. The pharyngeal phase is next, and this is when the bolus goes from the back of the oral cavity, so the mouth, the oral cavity, and then goes into the pharyngeal cavity or the pharynx. And goes right into the opening of the esophagus. So the triggering of the pharyngeal swallow occurs. The sensory receptors are receiving this input. They're feeling it, and so that's triggering the swallow. So a number of things are taking place during this phase. The nasal cavity is closed off from the oral cavity because the velum is elevated and retracted. The larynx is raised and moved forward. The vocal folds are closed and protected and protect the trachea. No food and liquid is able to pass into that airway. The bolus passes into the pharynx. The tongue works together with the muscles. And it only takes about 1 second for this to happen. So this is pretty fast too. Then we have the esophageal phase. This is, the esophagus is that muscular tube that lies right by the trachea or right behind the trachea. It is open at rest to allow air to enter the respiratory system. So the esophagus is a flattened, collapsed tube at rest. But when movement of the bolus into the esophagus occurs, this upper esophageal sphincter, which is this muscular ring that closes, joins the pharynx and the esophagus. And then it opens. It's important to know that the opening of this sphincter is tied directly to the pharyngeal stage of swallowing. So the upper sphincter is normally closed, and then it opens right during the pharyngeal stage and right at the beginning of the esophageal stage. So during swallowing, it relaxes and it's pulled open as the larynx moves up and forward. So you can feel the movement of the larynx during the swallow. If you put your hand on your Adam's apple, you can kind of feel that movement. Something called peristalsis begins as the bolus enters the esophagus and continues until the food passes. Peristalsis is where the bolus passes through the esophagus because of sequentially timed muscular contractions. So it's all kind of happening together to work with the food. And then it enters the stomach. This phase is about 8 to 20 seconds, so it's a longer phase. You can read more about this in your book, and I would, because I think it's going to make much more sense, 193 through 195. So we just talked about normal swallowing. So let's talk about disordered swallowing. What's going to happen if someone has an inappropriate swallow or a disordered swallow? So it's called dysphagia, remember? And it can result from a variety of disorders. Complications that can result from dysphagia include malnutrition, dehydration. You can have aspiration pneumonia. That's where the food goes into the lungs and causes pneumonia, and then eventually could cause death. So a diagnosis of dysphagia indicates that there's an impaired efficiency of the bolus transmitting from the oral cavity away through the esophagus into the stomach. So there's a breakdown somewhere in the swallow. So we have to evaluate the whole process of the swallow to see where the breakdown occurs and see how efficient the swallow is. Remaining food or liquid that's left in the mouth, the oral cavity, or the pharynx is called residue. And so it's important to take note of that. Also, something called penetration and aspiration occurs when there's a swallowing disorder. Penetration is when the patient attempts to swallow, but the residue from the bolus enters the laryngeal cavity. So penetration of large piece of food in the laryngeal airway can cause a person to choke. And that's when you might need the Heimlich maneuver. So you might have had that before, penetration. So it's not all the way going into your lungs, but it's like kind of getting caught. You can feel it in your trachea. Smaller amounts of foods or liquids may penetrate into the laryngeal airway that do not result in choking. So you may have had something, you might have heard someone say, that just went down the wrong pipe or the wrong tube. That went down the wrong way. And you hear this coughing, and they're not choking, but some kind of went down the wrong way, and that might be penetration, or is penetration. But it doesn't really necessarily lead to choking. So penetration below the level of the vocal folds into the trachea is called aspiration. And that's when it's actually going into the trachea and then eventually the lungs. And then aspiration pneumonia occurs when food or liquid enters the bronchi of the lungs. So it can cause, that's when infection occurs or can occur. So when I was in graduate school, we looked at a chest x-ray of a patient who had aspiration pneumonia, and he actually had noodles in his lungs, like spaghetti noodles. So he was aspirating so badly that the noodles were like going straight into his lungs. It can be really bad. So once the noodles were in there, it's really hard to get that food out, so it's caused infection most likely. So these infections you can have fever, coughing, lung discharge, fatigue, and then even death. So it can be very serious. So patients can have trouble in the oral cavity, forming the bolus, difficulties with the lips, jaw, tongue. So that oral prep phase, there can be a problem. Food can fall out of their mouth during this phase. They're not able to chew. Liquids may prematurely enter the pharynx and cause that laryngeal penetration or aspiration. Sometimes there can be a delay in moving that bolus from the oral cavity to the back of the mouth. That can be because of muscular weakness or any an inability to perform motor movements normally, follow a command. There might be decreased oral sensation, so they can't really feel it. Patients may have trouble chewing or breaking the bolus apart. Certain textures or consistencies may be hard for certain patients. There can be coughing or gagging during the pharyngeal phase if they're not able to form an appropriate bolus. So when the bolus is moved to the back of the tongue, to the esophagus, there can be a delay in the swallow, and that can result in coughing or choking or even aspiration. We talked about that the velum closes during this stage, so sometimes that can be delayed or may not, or velopharyngeal closure may not happen at all. And so patients may exhibit things coming out of their nose. So food can come out of their nose. If that may have happened to you when you laugh when you're talking with friends and Coke or water has shot out of your nose, or and that is because you're talking or laughing, so the velum and the pharyngeal wall are not making contact, and so that liquid can come up and go through your nose. Some patients may exhibit esophageal backflow, so where it goes back into the esophagus. You need to think of that swallowing mechanism as tubes and valves all working together. The oral cavity, pharyngeal cavity, the esophagus are all passageways for that bolus to flow. So just like pipes in your house or transporting water, that's how your book describes it. These valves, and I have this system outside in my yard where I have 3 different hoses hooked up, and there's one main switch, but then there's all these little switches that control all the little hoses, and I'll be trying to water the front flower bed, and I've turned on the wrong hose. I have to go back around the house to turn on the right one and switch this valve, and then open the other valve, and then close off the other valve so I get the right pressure for this valve. It can be very complicated because it'll be dark sometimes at night when I'm doing it, or early in the morning, and I'll forget which one turns on which one, the other one, and so it can be kind of complicated. Hoses and valves, and so that's how you can think about swallowing. It's pretty complicated. So there's different valves that have to be opened or turned off or closed in order for other valves to work and function appropriately. So certain swallowing disorders that are associated with organic conditions. So a person who's had a stroke, 30 to 40% of those patients will have dysphagia. That can be because there's muscle damage somewhere. They've had some paralysis or some weakness of those muscles for speech, so they're going to have the same weakness for the muscles for swallowing. So they may exhibit dysphagia. TBI that we discussed in the previous chapters could be a result of a trauma, and those people can have changes in their neurological state which can affect swallowing. They may have a delayed swallow or absent swallow or a delayed response. ALS, which we talked about before, is that amyotrophic lateral sclerosis, where there's weakness, and it can definitely affect swallowing and speech. My friend that I told you about who had ALS, she had a lot of difficulty swallowing because she had a lot of Ensure, and she couldn't really form a bolus. She would eat, some small bites of things. I remember her eating tiny chopped up fish. She would eat that, like raw tartar, but not very many other things. She was severely underweight. Parkinson's disease. this affects swallowing because of those because of those dyskinesias, like the hyperkinesia or hyperkinetic dysarthria, or the hypokinetic dysarthria. Remember those that affects the muscles and the movement of the muscles, so that's going to affect the swallowing. Head and neck cancer. So there's often a team of people that work with dysphagia. So that would be the SLP, the physician, the radiologist, the nurse, the dietitian, respiratory therapist, social worker, otolaryngologist, neurologist may be involved, a surgeon may be involved. Just a variety of people are going to be involved in the treatment and diagnosis of someone with a swallowing disorder. So the speech pathologist usually works closely with the doctor through written reports. Usually they often work together with a radiologist to determine what the swallowing disorder is. They may work with a primary care physician or the nurse to determine what medications they're on. They may work with a dietitian to determine how to get proper nutrition, if they're changing the consistency of the food that they're eating. A respiratory therapist may be involved depending on the patient's medical condition. So if they have a tracheostomy or a breathing tube, the speech pathologist will need to talk to the respiratory therapist. Also, a social worker can be involved to help with if there's any changing, if they're on maybe they have a feeding tube and maybe they're moving to other types of food, or they're having to go from one consistency to another and they can't eat certain things that they're used to eating. They may need some behavioral support or some counseling. It's also important that the patient be a part of this team. So let's talk about evaluation of swallowing. One thing we have to do first is to screen. We want to screen the swallow, and we do that maybe outside. So if a patient's in the hospital and you've gotten a referral from the nurse, then you want to collaborate with the nurse, the doctor, whoever has referred you, and find out the reasons why they've referred. Is the patient showing signs of aspiration? Are they coughing? Are they having temperature spikes after they eat? Are they having any pain in their throat or neck? Are they taking a really long time to complete their meals? Are they complaining of choking or coughing? Are they drooling? Is the bolus falling out of their mouth? Are they having trouble with mastication or chewing? So we find out all this information from the nurses, and then we also observe the patient. We will give them very tiny amounts at the bedside of food. We don't want to give them anything that they might choke on or cause any aspiration. So you might give them a sip of water, a little bite of applesauce, and you watch that swallow, and you kind of see if there's any problems with the temperature. If they have a temperature after they eat, or they cough or throat clear. Does their voice sound gurgly like mine just did? Did they have any discomfort when they swallow? If it does sound gurgly or wet, that might mean that their vocal folds, that the food went down the wrong way, and so the vocal folds are wet from the food, and that would mean they might be penetrating or aspirating. So after you've done a bedside and you've taken note of different things, you might then recommend that the patient have a formal swallow study or an evaluation of swallowing, which would include either video fluoroscopy or fiber optic endoscopy. So that can be either the modified barium swallow study or video fluoroscopic swallow study or fiber optic endoscopic evaluation. So that's FEES or VFSS. So the modified or the video fluoroscopy is where you're working with a radiologist. The patient has barium, which is this liquid that they put with the food so that you can see the actual swallow on an x-ray machine. So you and the radiologist are watching the swallow together to see if there's penetration or aspiration, to see if the food is going into the esophagus correctly. Is it is any food staying in the vallecular piriform sinuses? Is that transit happening normally from oral and pharyngeal phases? What's going on with mastication? Is there any misdirection? All of that. So you're watching that with the radiologist, and it happens very quick, so it's very important for you to have a really good eye so you can tell if that swallow is normal. So it takes a lot of practice to watch a lot of swallow studies to see and to learn what's a normal swallow and what's abnormal. Another way to view a swallow is through FEES or fiber optic endoscopy. And you and the physician, again, are working together. You're watching that oral transit of the bolus into the pharynx, the velar closure, the pharyngeal muscles, the squeezing action, the vocal fold closing, the epiglottal movement. You're looking at all of that. But you can't actually see the precision of the swallow, so you can't see that moment when the swallow actually occurs. However, you can see the pharyngeal and laryngeal structures after they return to their resting positions. So you can tell if there's any dysphagia. You can tell if there's anything that happened that's not supposed to. So that could be like food or liquid remaining in the pharyngeal cavity, or even in the laryngeal entrance of the airway. So you can see all that through FEES. It allows you to visualize multiple swallows with a variety of food consistencies. So it helps you to see which food consistency is better, whether it's thicker or thinner or different textures. And also you're not getting any radiation exposure. So this FEES can take a long time, whereas like the video fluoroscopy, you don't want to watch them eat a whole meal because that's a lot of radiation exposure. But with FEES, you could watch a meal be completed because it's not going to be any damage to the body with the endoscopy. So it's important to determine the safety and efficiency of the swallowing during both of these procedures. So we want to make sure we're not giving them too much of something. So for example, if they're aspirating on thin liquids, we don't want to keep giving them thin liquids. We want to find ways to help compensate and help them not aspirate on things. So we might need to thicken the liquid, make it a little thicker. There's you can use cornstarch or actual thickener to actually make these liquids a little bit thicker while they're drinking them, while you're testing them. So after dysphagia has been diagnosed, then you want to work on treatment. So you need to develop a treatment plan. And so then you're going to determine what is the best way for one to swallow. So do they need to change the posture? Do they need to have diet modifications? Do they need to try a different swallowing maneuver? So a posture might include something with the head and neck. You may need to turn the head or tilt the head. You may need to tuck the chin. All of these are strategies that might help the swallow be more effective or safer. You might try some swallowing maneuvers where the swallow is actually more effective or efficient because of certain things that you're doing. So for example, the Mendelssohn maneuver is one where you're actually increasing the pharyngeal opening for the bolus from the pharynx to the esophagus. So you're actually making it bigger. So you're kind of lifting up the larynx. So, for example, when you swallow, you feel your Adam's apple. So you feel it as you swallow. So try that now. So try to swallow, and you feel that Adam's apple move. But Mendelssohn mover, you lift it and you don't let it drop. So you hold your larynx up for 2 seconds and then you let it relax. So the SLP helps with these different maneuvers to maybe help the patient swallow more effectively. And then diet modifications, like we talked about a while ago with thickener, you might add thickener to their, you might recommend that their diet, everything be thickened to a certain consistency. So they may have to have pudding thickness, or they may have to be at what's called mechanical soft. So minimal chewing is required. Soft texture foods. If you look on table 9.1 in your book, it kind of gives you what the National Dysphagia Diet is. There's different levels. So at level 1, it's pureed. At level 2, it's a little bit more texture, mechanical soft, and then it's a little bit more advanced at level 3, where you can have bite-sized foods, but no crunchy or hard or sticky foods. So it's going to be a little bit easier. And then at level 4, it's all foods are allowed. So, and then there's the thickness level. So thin liquids are like water and coffee. Water's the thinnest because there's nothing in it. It's just thin. And then there's like that nectar-like consistency. It's a little bit thicker. Honey, and then spoon thick is kind of that pudding consistency. We actually used to call it pudding consistency, but they've changed the name of it to spoon thick. So sometimes you'll see, you may read on a medical chart when you're in SLP, if you're filling in for someone as PRN, or somebody else has already recommended, another SLP has recommended spoon thick liquids. So you would know that's like that pudding consistency. So you would have to make sure their liquids were at that consistency. Or you may recommend nectar thick as an SLP, or thin. They may go back to thin after they've practiced some of these maneuvers and they've gotten healthier, so they can move from that spoon thick to honey thick, and then eventually back to thin. And so you're making sure the nurses or the doctors are complying with this. So you get to make these recommendations depending on what you've seen in the evaluation. So there are swallowing exercises and sensory stimulation that can occur as well. So for example, you might, in the sensory stimulation, you might make the liquids very cold or hot, or whatever you need to do, sour or more carbonated, so they can actually feel the liquids if they have decreased sensory awareness. You don't, of course, don't want to burn their mouth or anything. Be careful with that. You may do tongue exercises to help with coordination, to help with the control of the bolus. You might do some lip exercises to help them hold the bolus in their mouth if the bolus is falling out. So there's a lot of different things you can do to help with the swallow. Education and training is critical, not only for the patient, but for the family, to show them how to make their liquids if they're making them thicker, to change the textures. If they're doing certain exercises, teach them how to do the importance of the nutrition and to show the signs of dehydration if they're not getting enough liquids, if they may need an IV, or even some patients need feeding tubes, which that can be very controversial for some families. Maybe their parents, and they've gotten older, and the only thing they really enjoy is eating, and then you're going to take that away because they're aspirating. I mean, I've seen this in hospitals, and the patient just absolutely does not want the feeding tube, but they're aspirating, so they need it. So that patient I was telling you about with the spaghetti noodles, I mean, they did not want a feeding tube, but that patient was at risk for death because of that pneumonia. So there's something called feeding tubes, or non-oral feeding options, which that would include the nasogastric tube, which goes through the nose, or the gastrostomy tube, which goes directly into the stomach. And those are non-oral ways of feeding. And sometimes patients need need that, depending on what the severity of their dysphagia. So, swallowing disorders do not just occur in the elderly population. There's something called pediatric dysphagia, and that can be caused by cerebral palsy or anatomical differences such as cleft palate or gastroesophageal reflux disease in babies, respiratory diseases, or someone with a tracheostomy, developmental delays, even disorders such as autism. A child can have pediatric dysphagia. So babies can have it. They can't suck. They don't have the good suck, swallow, breathe with a bottle. That I've worked with infants that I've had to teach how to suck and help them with that, with feeding very young. When evaluating an infant or a child, swallowing will always be looked at according to developmental milestones. So you'll look at their neurological maturity, the developmental maturity, any gastrointestinal problems. You'll always work closely with a pediatrician and other providers such as the OT or PT. And then in the geriatric population, age 60 and over, you always want to look at the swallow, taste changes, muscles of the tongue, pharynx, if they become weaker, have they had a stroke or any other disorders that might have caused these problems, and you got to take all that into consideration. So this chapter we reviewed swallowing and swallowing disorders, and I highly recommend that you read through your book and you also look at the other documents that I've posted in Blackboard. And I hope you enjoyed this lesson.